Okay, so hopefully you've now done your ethical matrix for a couple of genetic diseases. So if you've picked something like Duchenne muscular dystrophy, hopefully you would have come to the conclusion that this is a really serious disease. It causes extreme suffering, and if any diseases were to be approved for prenatal testing, giving the parents that information to terminate that fetus, then this would be at the top of the list. Other diseases that will be up at the top of the list would be cystic fibrosis, very major disease, lots of individuals born with that each year. Huntington's disease, certainly right up at the top of that list. Now, a lot of the others are a little bit more contentious. Early onset Alzheimer's disease, actually not contentious, probably about as severe as Huntington's disease, really, really unpleasant. The ones that traditionally have caused students on this module problems is hereditary blindness. Now, lots of people who are blind would say this disease does not cause me extreme suffering and I live a perfectly fulfilled life. So the thought of testing for optic atrophy 1 leading to severe vision loss in an autosomal dominant manner might seem to some to be a bit unethical, to test a fetus and then terminate that fetus on the basis that it will be blind. However, that is on the approved list, and that raises a few eyebrows, certainly has raised eyebrows with my previous students. Phenylketonuria, I sort of alluded to it earlier. It's entirely treatable with a low phenylalanine diet. However, due to issues of parents potentially having the disease and whether they could maintain that diet, if we didn't test for this, then we would be ending up with a lot of individuals very negatively affected by it. Now, other hereditary metabolic diseases which are entirely treatable are not testable by prenatal genetic diagnosis. We treat them and the individuals are absolutely fine. But because a lot of the individuals are not fine with phenylketonuria due to the difficulty in maintaining that low phenylalanine diet, then this is on the approved list, because if they do suffer from the disease is really quite severe. A couple of diseases that are need to be compared is the hereditary breast cancers and the hereditary melanomas. Hereditary melanoma caused by the P16 gene. Now the main difference here is hereditary melanoma has a 20 to 30% risk of melanoma by the age of 40, and it's almost entirely reduced by avoiding direct sunlight. So if you're aware of the condition, you can reduce your melanoma risk, not quite, but almost to the normal population's risk. In contrast, hereditary breast cancer, the number of people who will develop this, if you inherit the mutation, it's autosomal dominant. Let's just sort that out first. If you inherit that, your chance of developing breast cancer is anywhere between 50 and 80% for most mutations. May even be 100% for other mutations if you live long enough. So this raises the difficult concept of penetrance. If this is 80% penetrant, that means you've got the mutation, there's an 80% chance you're going to get the disease, then maybe this is more of a prime candidate for genetic testing than hereditary melanoma, where there's a penetrance of 20 to 30%. And when these conditions were considered a few years ago, hereditary breast cancers were approved on the basis that both of them have a 50% plus penetrance. They can be prevented, but that means a double mastectomy, and for BRCA2, hysterectomy and ovarectomy if there's signs of changes in those tissues as well. So that's very significant surgery to prevent that disease from occurring. Whereas with hereditary melanoma, you can avoid sunlight and there's only a 20 to 30% risk of melanoma. Now that's much higher than the normal population, but it's seen as that this particular disorder is not as severe as the other one, as a hereditary breast cancer. Therefore, and the last time I checked on this fairly recently, You couldn't do prenatal testing for hereditary melanoma, but you could do prenatal testing for BRCA1 and BRCA2 breast cancer. Hopefully none of you thought that someone with colour blindness, a fetus with colour blindness, should be terminated on that basis. It's not technically classed as a disease, and the only thing you can't do is operate certain types of machinery. You can't join the RAF, that type of thing. It's not something that causes extreme suffering. So if you want to check your particular disease and see what tests are available, you can check this particular website here. It's the Human Fertility and Embryology Authority's website, where it's got a list of all of the conditions that can be tested for pre-implantation genetic diagnosis. Now we're going to talk about that next week, but all of the conditions that are suitable for prenatal are also on the pre-implantation list, with a couple of odd exceptions that I'm going to talk about next week. So the whole list of diseases which do not cause considerable suffering, and therefore they would be genetically diagnosed in an adult, and they'd be genetically diagnosed in a newborn child, but they wouldn't be tested for in utero with the aim of allowing the parents to terminate on that basis. And ocular albinism is one of those. It's the absence of melanocytes, so very pale skin, very lack of melanocytes in the eye, and yes, it does cause visual problems, but you would not be able to terminate or even test the fetus in utero for this condition. Mild metabolic diseases which are treatable are not testable, and some forms of progressive deafness. If the deafness comes on and develops through life, then presumably patients are able to learn sign language during life, and the deafness is not seen as causing significant suffering. When you look at this list, some of the genes that I talked about were not on there. So colour blindness is not on there at all because we just don't test for it. The ApoE allele is not on there because it's not a classic disease gene, it's just a risk factor. So we wouldn't clinically offer these to anybody. A really important point up here is that we can do genetic sex selection. Now we can't do it for no clinical reason, so if someone's pregnant and they want to know if it's male and do a genetic test and terminate on that basis, you cannot do that. However, there are clinical reasons why you might want to do this. And if someone's carrying a Duchenne muscular dystrophy, potentially affected boy, so if a mother has already had a Duchenne muscular dystrophy affected boy, and, which is the case in some cases, we don't know what the mutation is, because the Duchenne muscular dystrophy gene is huge. Sometimes we don't know what the mutation is, therefore you can test the fetus for biological sex. If it's female, you do not do anything else. If it's male, you offer the chance to terminate, knowing full well that half of those males that will be terminated would be non-diseased. But that's an odd example where it is allowed. Another situation that's not allowed is, imagine you've got a child that needs a bone marrow transplant and you are pregnant. You can't do HLA or tissue typing to aid the transplantation process. So it would be very, very unethical to permit someone to terminate a fetus on the basis that it wouldn't be a tissue match for an existing sibling. However, pre-implantation genetic diagnosis next week, this is permissible in some cases, and we're going to talk about that extensively next week. Finally, if somebody is a carrier of a genetic disease, let's say you've got a woman who has carrying a fetus and it's tested to be female, in this example I gave up here for sex selection, you would never look to see if that female was a carrier of that disease. If we're looking at Duchenne muscular dystrophy, if it's a girl, no more testing. If it's a boy, we look for the mutation. We would never report whether the female fetus is a carrier, and we wouldn't do that for any other genetic disease like cystic fibrosis. The reason being, you would be terminating a completely healthy individual that just happens to be a carrier of a disease that they are not going to suffer from. So that is the carrier status of fetuses that are tested is not reported to the parents. They're just told either diseased or non-diseased. So all of these genetic tests on fetuses are governed by the Human Fertility and Embryology Authority, and they license UK labs to perform these prenatal genetic diagnoses and also the pre-implantation diagnosis that we're going to talk about next week. And all of these tests are done in licensed labs, almost all of them NHS laboratories that also test for do routine genetic diagnosis in postnatally. Now, the HFEA have to approve something to be tested prenatally, and they work on the basis that is there a significant risk factor that the person with the abnormality will have a serious physical or mental disability or a serious illness in some way. So on that basis, if the answer to this is yes, then that particular disease can be tested for in utero. The parents can be given that information, and that information can be used for the parents to decide whether or not to terminate. Now, the key point is, not to get confused about, is that parents can choose to terminate a fetus for no reason given. That is always there. What we are dealing with here is using a piece of genetic information to inform the parents, and then they are going to terminate on the basis of that. So the factors that are considered by the HFEA on whether a disease can be tested for in utero is seriousness. Is it lethal? Is it going to cause severe problems to that individual? What is the age of onset? If the age of onset is 70, probably fairly low on the list. If the age of onset is even young or middle-aged, then that's really quite serious. So the late onset Alzheimer's disease comes under this age of onset. If it's going to come on at the age of 70 plus, well, that doesn't justify termination of that individual. Degree of penetrance. Does the mutation equal disease in all cases? If it does, it's 100%, and that would increase the likelihood of a disease being testable in utero. What we don't want to be doing is having a situation where 75% of the fetuses that carry a mutation are terminated, even though they would live an entirely normal life without the disease. The symptoms of the disease, that comes on the seriousness. Is it a particularly a really, really unpleasant disease, or just a moderately unpleasant disease? You also need to consider whether it's treatable. So I talked about phenylketonuria that is treatable. There's also another disease called MCAD, medium chain acyl-CoA dehydrogenase deficiency. Now this is an odd one, because this is one that I have tested for prenatally many, many decades ago when that was allowed and it was on the list. But then the HFEA or equivalent back then in the late 90s decided that it shouldn't be on the list. So diseases can go on the approved list and then have a review and drop off the approved list. So in the, let's say, mid-90s, when I was testing MCAD in a genetics lab, it was on the approved list. A few years later, it wasn't. So that sort of disease is entirely treatable. There is a split decision about whether it should be approved or not, and its status has changed a couple of times. I suppose the main summary is, does the disease have a serious effect on the quality of life? Speed of degeneration in progressive disorders. If something progresses very, very slowly, it might not be approved. If something progresses very, very quickly and results in death, then it's more likely to be approved. And especially anything that causes any intellectual impairment, if they are beyond mild, are likely to be approved. So if you've not already done it, I really want you to complete this ethical matrix for a couple of diseases. Pick something that is really quite severe, pick something that might be on the borderline, and consider all of these things from the point of view of the parents of the fetus, the fetus itself, about it being born. Should it, is it right that the child should be born with this disease when you can do something about it, that type of thing. Consider the society side of things, about should society have a choice in this, and consider clinicians. And just remember the fact that I raised with you last week is that due to lots of genetic testing, Down syndrome is virtually absent now in Iceland.